Are there dynamics that are worthy of exploration and shifting away from this is not about a blame approach, it's really empowering. If you just skip over that, you're actually taking away their power. You're disempowering them to have more influence. We don't discover and explore these things with neutrality and compassion. We really miss something very exciting about helping people heal that has much more far-reaching effects than just changing someone's behavior temporarily.
You've arrived at the Mental Health Spotlight podcast with therapist Kais. Wendy Oliver-Pyatt, did I get it all correct?
Yay!
Well, what's so funny is we had this great Northeast Ohio Eating Disorder Collaborative this past week here. Within was here. Kelly was here.
I saw that. I think I saw that.
I thank you and your organization for being a part of it.
Oh, cool.
And she's like, oh, Kais, I'm so excited you're going to meet Dr. Wendy. And every time I heard your name, I was like, yeah, that's going to be really fun. And the name was making me itch. I'm like, what is it with this name? And then, of course, it dawned on me that you're also the Oliver-Pyatt Center.
Yes.
You are so many things, Wendy. I'm a little overwhelmed by all of your things. I don't even quite know where to start.
What are you doing now, Wendy? Yeah.
I used to refer to you, and I'm like, oh, here you are.
Oh, thank you.
I would never do your bio justice because there's so much on there. I don't know how you'll even give us a little snapshot, but tell us a little bit about, I guess, really what started you, your background, and then how that has brought you into all of these different eating disorder settings.
Thank you for having me. And my background really, I'm from a small town in Carson City, Nevada, and I was very involved in ballet. So that was a big part of my life. And this was back when nobody knew anything about the concept of weight stigma, diet culture, even eating disorders. Nobody really understood. So at that time, early in my life, I kind of fell into restrictive eating because of being in ballet. And then that led to my own kind of struggle and then, thank God, triumph to get through to the other side. I was very, very fortunate because I was blessed to stumble on the principles of mindful eating very early on. So by the grace of goodness, God, whatever, I found my way into the concepts of mindfulness and mindful eating, and that just opened up a whole world to me of not just a way of approaching food, but really a way of approaching life that really was very meaningful to me. And in my early 20s during medical school and residency in New York City, I sort of became, I evolved. I think I was telling you in the pre-recording that I feel like I grew up in New York. And I just learned, I honestly did a lot of self-help and self-exploration. I read M. Scott Peck, The Road Less Traveled, and things like that go way, way back. And read some of the books by Janine Roth that are sort of the pre-intuitive eating books. Yeah. And there was even a writer before Janine Roth. So all of those people kind of influenced me. I fell in love with psychiatry during medical school accidentally. I was planning to do OBGYN I was planning to be a veterinarian, then I switched to OBGYN, but then I did my rotation in my third year of medical school at Kings County Hospital, encountered my first psychotic patient, and just was blown away by the watching and being a part of somebody going from a state of florid psychosis to lucidity. And I just fell in love with learning about the mind. So I just kind of shift gears and decided I really was meant to be a psychiatrist. And that was really something that I grappled with because it really was also a opportunity to have that shift into the paradigm of what really internally motivates me versus externally motivates me, which is a kind of a thing I talk about with my patients a lot. And so it was really I wanted to read the journals that had to do with psychiatry because I was genuinely just interested. It wasn't like I should read it because I need to know that I'm going to be an OBGYN. It was I just genuinely, intuitively was drawn to the mind and the soul and healing. And so that led me into psychiatry. Very long story. I could go on, but I went to the state of Nevada. I became the state of Nevada medical director for Division of Mental Health. We got funding to do assertive community treatment programs and stumbled into the opportunity to do eating disorder work with one of my coworkers. I had written a book about eating disorders and disordered eating.
You'd already written a book by then?
I wrote a book in 2003, yeah.
Oh,
Yeah,
interesting. I did
that
not
and
know that.
like, that led to some people inquiring, whether or not I would wanna open a treatment center for eating disorders, and I just, I decided, yeah, I think I will do that. So it was just kind of a sometimes I either think of it as bold or crazy. I definitely had imposter syndrome and it was like, what am I doing? But I had people behind me that believed in me and I opened my first treatment center, Center for Hope of the Sierras in 2003. And it just kind of took off from there. And when we figured our own way of treating eating disorders based on like truly organic process and individualized approaches. So I had never been in a treatment center or seen a model or it was just this is really based on like the
Wow.
human being in front of me. And so my curse was that I had no experience developing models, which was my blessing. So that's still a very long answer, but it just took off from there
No.
and just never stopped.
I love that, and it tells us that your original background is mindfulness and then medical, and you've made a
Yeah.
confluence of both of those is kinda what I'm hearing in your story.
Yes, I think
Yeah,
one of the things I really believe in is being true to a biopsychosocial foundation and really
yeah,
understanding your patients that informs your treatment and that, behavioral approaches need to be really trauma informed and behavioral approaches have to be grounded on like a psychodynamic formulation. So I used to always kind of insist that our therapist really be able to, in a way, like once you get to know the patient, you should have in your mind a framework of like the psychodynamics that are driving forward the eating disorder, whether it's temperamental
mm,
features or sociocultural factors, family dynamics or whatever, but to have an understanding of like the why of the eating disorder, the how of the disorder, the function of the eating disorder, because
love
it's
it.
imperative to get to the underlying dynamics that are driving the behavior, not just only focus on the behavior.
And did you find at the time that other people weren't approaching it? Were they more looking at a symptom approach and just trying to come up with, like, a brief solution base?
I think that's kind of been one of the problems in general with the field. I'm not saying
Yeah,
every program is like that, but I think that while I, am a physician and obviously the medical aspect of eating disorders is like very first and, right in front of me at all the times. But
yeah,
I just think the oversimplification of, oh, you just put weight on somebody and then their brain's going to work great and then they'll be done. I think sometimes we want to go that route because we don't want to feel like we're blaming people, right?
right,
And I
right.
think there's a way to actually be more authentic and more honest with folks by helping them see we don't discover and explore these things with neutrality and compassion for both the patient and the other parties involved. We really miss something very exciting about helping people heal that has much more
Yeah.
far-reaching effects than just changing someone's behavior temporarily.
Oh, I love that. When I work with young people, I say, "This could be transformational for your whole life. This isn't about whether you had this meal today." Like,
Yeah.
what
Yeah,
a
and it's
journey.
also can be that one person with the eating disorder can the shift in the dynamics if we're exploring it with, like, compassion and curiosity for the whole system, it can actually help the whole system. It can help the whole unit or
Yeah.
family or group function better and be happier, be at more peace, less things, like, hidden from words and language in the relationships, which brings more closeness, actually.
Yes, and less shame. If we're talking about it and making it
Oh, yes. Yes,
present, it can't hurt us as much.
about less shame. I'm glad you mentioned that. That's
Oh.
central.
It's in what you're saying. It's and I know you said we don't wanna point at people's worlds, but our worlds do shape us
Yeah,
genetically, externally, and we have to
yeah,
look at those.
yeah,
You know,
absolutely.
I think of 12 step, they you don't just not drink, you have to go through an entire program of personal evolution to get better, or
Yeah.
recidivism is huge.
Addressing shame is, like, fundamental to really any kind of mental illness, whether it's an eating disorder or substance abuse or something else, but shame is really that, one of the underlying drivers of people needing to bury their feelings, of course. So,
Yeah.
I love doing talks on shame, I love sharing about shame, I love doing experiential, um, processes with clinicians around around shame. Had some really great experiences with that, and that's, like, super freeing and exciting.
Oh, I love that. And we don't talk about it enough. It's almost like a trend word that we just need to really own even more, and it should be part of every recovery
I
process, right?
agree. I agree. I agree.
Obviously, you wrote it. I'm just talking from what you've already created. I've
Thank
learned what I've learned because you were the pioneer to bring
Oh, that's so
this language
sweet.
forward.
I was stumbling into everything. Hey, there's the shame thing. Hey, weight stigma.
I hear that so much with people I interview, and I think it's because this is all so new. This
Yeah,
is still such a new world that we're crafting. And again, I call you a pioneer because you really are. If it wasn't for people like you stumbling and searching, we wouldn't have this conversation right now. So
thank you. That's very, very
thanks.
generous of you. Thank you for
Thank
saying
you for doing that.
that. Thank
So you
you.
came out with this with your own version of a model based on what you believe so strongly. And then a lot of places took this on. Like, do all the places you had Clementine, Oliver-Pyatt that you
Yeah.
use this same model at? Are they all
Yeah,
similar?
yeah, I would say very similar. I mean, I my first treatment center was in 2003, and there's been sort of like obviously an ongoing evolution since then, leading to Galen Hope and Within now.
Yeah.
And I tell people, yeah, my program may be 5 years old, but like it's 23 years in the making, and
Yeah.
I would say, some of the things that I particularly love about it, which I could go on and on about things I love about it in both Galen Home and Within. The
Uh-huh.
way we do food is really, really special. I think people tend to, this sounds a little judgy, I'm sorry, but I'm opinionated about it. And I think when people are thinking about their own healing and like what they need to do, if they do have to go to higher levels of care, really understanding like how are they going to do food? What's the approach there with
Okay.
food? How do they actually handle food? Because there's a wide variation there of how it is handled. And it has far reaching effects to really give that consideration. So I've always been very grounded on helping people shift, I think, away from what I would call external regulation or rule governed eating toward internal regulation tied in between it becomes sort of a combination of intuitive eating and mindful eating, but the early stages of it for many patients is really a mechanical eating process because you're actually having to do exposure therapy. I'm
Right.
a really big believer in going very slow. I'd much rather approach individuals and get exposure to a very broad array of non-diet foods so that people are able to eat the grilled cheese sandwiches and the things that are very, if you're a college student, I want you to be able to eat pizza when you go back to college. If you're a mom or dad, I want you to have birthday cake. So we have to do a lot of exposure therapy, but I really, really do believe for both medical and psychological reasons starting low, go slow. Slower is sometimes really
Slower.
faster as far as like long term. So there's some really creative ways that we've helped people shift into internal regulation. And it really is a developmental process as people are healing and really helping people take accountability. And I use the concept of a Montessori concept of like freedom and responsibility are intertwined. So like as somebody is more responsible to themselves, they ought to have more freedom. So using a non-punitive, developmental, natural consequence approach is really a way I think that people can heal from the inside out. And so some really interesting ways we've evolved in how we do food. I think that help people get out of diet culture mindset. And really a big goal of mine is to help people become as far as long as they can on the continuum towards mindfulness and intuitive eating. And really important is to abandon the pursuit of fitness.
Oh, well, you just said two huge things there. You ended with abandon the pursuit of thinness. I'm going to
Yep.
come back to that. But you mentioned your food tenet that you hold.
Yep.
And I want to highlight too that now you are currently CEO and overseeing Within and Galen Hope. Is that correct?
Right.
Both of
Mhm.
those?
Yes.
Can you tell us a little bit about those? And I have to laugh because I found this I just hit myself with that.
Oh,
Found that in my,
yay! I love Color Within.
oh my gosh. I have the socks too, and I wear them
I love
together.
that. I should have my Within coffee mug with me, as a matter of fact. How terrible of me.
I got your back.
Thank
I
you.
don't have Galen
I
Hope's
have to
then.
send you a hat from Galen Hope right away.
Perfect. But tell us a
Um,
little bit about these two,
yeah.
because I believe Galen Hope is in Florida and Within is your virtual setting.
Yes, yes,
Okay.
yes. So, Within is now, I believe, in about 42 states, I think 43. I'm not sure. I've lost track. We got to get up to 50, but we're coming along.
You're there. Yep.
And Galen Hope is in Coral Gables. Galen Hope also treats primary mental health. I Remember,
Oh,
I
good.
told you that story about my psychotic patient way back when. I do love
Yeah.
primary mental health, treating OCD, trauma, depression, bipolar disorder, psychosis. All of that is a true passion of mine. So I'm very fortunate at Galen Hope I can do both eating disorders and primary mental health, which is really, really exciting
Beautiful.
for me. So Galen Hope is in person and all levels of care going up through residential. And then within is a remote program, and I call it remote specifically, just so you know, because
Yeah.
the relationships are not virtual. These are very real relationships that our patients are embarking upon. We with them, they with us, and amongst them, some very deep and meaningful connections, attachments, and relationships, and healing relationships evolve. And I think, both programs are derivatives of like 20 plus years of work. I'm so lucky because when I started both programs, there was a sort of little mini army of wonderful people that had all worked together back at OPC and Clementine. And so when I started Galen Hope and Within Health, I had such a strong team to help me launch. That was why I was able to do it, because I didn't have to do so much legwork, as the team was
Mm,
really
yeah.
I mean, we already had teams that were solid and really knew how to do the work. So that was truly exciting for me to see that those teams come to fruition again. So within is really the embodiment of like 20 plus years of work. And what I did is I pictured walking into one of my treatment centers and I said, what's in this door here when you walk in that's like healing for patients?
Yeah.
And I mean, the truth is like Galen Hope has basically the same principles, but I'll just start with within, or I'll go to the within, because people sometimes wonder, how do you work with such acute patients in a remote setting? And I
Yeah.
wasn't sure if we could.
And this is all new, isn't it, Wendy? Like, you weren't doing any of this pre-COVID, were we? Were we allowed to do remote back then?
We started this in 2021. I was doing remote care for eating disorders going back to like 2018, 2019. And that's what
Yeah.
got me the idea even before COVID. I was like, wow, like I work with patients that were pretty compromised. Like I had people that couldn't go to treatment. Like I had somebody in a European country. I had somebody who was a dolphin trainer, as a matter of fact. And I was doing high frequency treatment. So I was kind of covering psychiatry, nutrition, and therapy and family. I was just doing a lot of like intensive work. And I was going, wow, this is a person who was purging, who was over exercising, who's restricting. She's getting better. And I'm not sitting over her, she's
Right.
not in a treatment center. So that got me really excited before pandemic even came. But I think, some of the things that are really important is, among many is high frequency of individual therapy. So I really
Yeah.
believe that when somebody comes to treatment, we're talking about the underlying dynamics. Like you can't get to the underlying dynamics if you're doing like a 45-minute session a week. So you
Yeah.
got to invest in the therapy. You have that person under your umbrella for a very limited period of time. Like, what are you going to do? Like, it's a sacred opportunity. By the time somebody has decided to come to a higher level of care, they've suffered a lot. Even at the
Yeah.
IOP level of care, they've suffered a lot. They're making the decision to come to 12, 15 hours a week of treatment. Like, you have to be pretty hurting to do what's almost the equivalent of a half-time job, like coming to treatment. So,
Yes.
that high frequency of therapy is like our investment in the patient and ultimately in their
Love that.
healing. And that's something I just don't think you can cut corners on, having therapists that are really curious and compassionate around those underlying dynamics. So it's this
Yes.
great journey together.
Just interrupt you for a
Yeah,
second.
sure.
A lot of times what I hear is remiss in other settings is they're not getting a lot of individualized care, or they're not getting a lot of the therapeutic piece that gets at the core. So kudos
Yeah.
to you for recognizing that.
Oh, I can't do
Yeah.
it any other way. I just cannot do it any other way. I feel
Yeah.
like it's punitive if you don't. And it's like you're
Right.
missing out on like the journey with the patient.
Yeah.
The symptom is the opportunity, as they say. The symptom is the way into the deeper
That's right.
self. So we would be really ripping the patient off and ourself off, I think, to not go on that journey. So high
That's it.
frequency of individual therapy is really important. Family and community. So not really just accepting it when the patient's like, oh, I don't want to do family therapy. well, guess what? We need to involve you. And so we have a model both at Galen Hope and within. It's a comprehensive approach where there's not just therapy, but there's also coaching and there's also education. I'm actually getting something published for Galen Hope. We call it the family integration model. It's very similar to what we do, very similar to what we do at within. We've modified things, of course, for each organization. But, even if the person is a really troubled relationship with others in their life or is really feeling like they are not ready to take those steps therapeutic, I mean, you still have to like dig in and not really accept that like, hey, this person's in relationships with these people in their life and they've got this really significant illness before us. So we can't just like sort of sweep that under the rug and pretend like,
Yeah.
yeah, we're not going to involve other people. It doesn't mean we always have to be therapeutic in the involvement. So it could just be that we're doing education with them. It could just
Right.
be that we need to educate people. It could be that we have to coach people. Like maybe somebody's not really, the relationship's not going to change a whole lot or whatever, but maybe a little coaching would help. And then, also pivoting and finding the right people to have the conversations. Like sometimes the coaching is best held, by maybe an authoritative physician from your team needs to talk with like
Mm.
the parents versus the
Yeah.
therapist, or sometimes it's the dietitian that needs to talk to the mom or about like, yeah, your loved one probably ought to not be doing track right now because they have amenorrhea, So
Right.
I like really mixing and matching who's doing the education and the coaching. We have Joe
Love it.
Kelly at Within, and he's done a lot of work around like I present with him on really the circle of care, the circle of loved ones. So it's beyond just
Yeah.
the family. And then at Galen Hope, yeah, we've just really established a wonderful model, and we do a ton of family work, and we do like a really beautiful family day where the whole family comes in once a month, and that's really, really appreciated by our families, and we really get to know them.
So some of the key things are this whole family-based and the integrative
Yeah,
thing you mentioned.
yeah,
There's the attention to a lot of therapeutic one-on-one time. And then
yes,
you said your food model, you mentioned that a little bit earlier. I want to make sure we come back to that. You said you have a very special way that you approach food. Well, can
yes.
you speak a little bit about that?
Well, some people are pretty surprised when they find out that I meet people who are very, very compromised with eating disorders, and I don't use supplements, don't use boost, don't
Okay.
give them Luna bars. It's, if you're
Mm,
coming to treatment, they used to always say like, well, the Oliver-Pyatt Center, the Galen Hope, it's like, it's a very pretty place, but the food is hard. We give
okay.
people some ways, to modify what they're being fed that's based on preferences. Like I always tell people, if I had an eating disorder and I had to go to treatment and they told me I needed to eat avocados, I would have a conniption fit. So people do have a way to modify their meal plans based on
Okay.
certain particular things that are non-eating disorder related that we're able to
Okay.
determine. And again, it's really the principles of exposure therapy that we're using,
Of course.
gradual supported exposure therapy is really, I think, a very important principle. And the shift away from external to internal regulation. And so, if you will, like rewarding the person with more freedom as they are moving in the direction of internal regulation and finding some interesting ways to positively reinforce the non-eating disorder behavior. And I think tied
Mm,
in with that, and this is something that doesn't get spoken about a lot, but when you're creating a treatment milieu, whether it's a remote milieu like within or in person like it, whatever, I think recognizing you're creating a sort of mini society, right? It's
yeah.
like the person coming to your treatment is making a sacrifice, giving up control, trusting, blindly believing in you, right? All of
Right.
these very big steps that they're taking. I mean, can you imagine like going away to treatment? Like you're saying, okay, you're going to control when I flush, go to the bathroom,
Right.
talk on the phone, watch TV, go to the
Yeah.
store, you're just giving up so much autonomy when you and even remotely we have parents that can't leave their kids. We have students that if they miss, X class, it's going to be another year till they graduate. And we
Right.
have people that might lose their health insurance if they were to go away for treatment. There's a lot of reasons people don't go to treatment that have nothing to do with a lack of motivation. There's just so many
Right.
practical considerations. We tend to blame the
Absolutely.
patient. I mean, just really thinking about what is my social environment that I'm inviting these patients to live in. So it's really a trick to strike that chord and like find a way to create the boundary around the disordered behavior and like still be affirming and validating and loving and supportive. And so I think that's something that we do really, really well.
Yeah. And you've given that a lot of thought. I really appreciate that you mentioned the autonomy, especially
Mhm.
with younger persons, because that's when they're supposed to develop autonomy. And then we're saying,
Right.
hey, by the way, you don't get to choose what you do. What a
Yes.
tough balance time. And
Isn't that
it sounds
terribly tough? It's terribly tough. Yeah.
it is. Yeah. And
It,
then
it
being able to, like you said, give it back as they're ready to internally motivate. And then to slowly, it's such a treat to hand it back and say, okay,
It
you go run
is.
with this.
Really is such a
Oh,
treat. Yeah, it's exciting when you see that happening. But I mean,
it
you
is.
really can think about the society you're creating and like, and amongst our lovely human patients too, like they really are a big part of the environment that we create and they lead one another to healing a lot of times
Yeah,
too. And
they are.
that's the best when you see that happening. I'm running a group, but I'll just kick back and let them all talk and just be like, yep, you guys
I
got
love that.
this.
They typically know more than we do, right? It's just organizing around it and letting it do that. Now, I
Yeah.
know if there's nutritionists or dietitians listening, dietitians are going, "Oh, wait, what about this no supplementation?
I
How do
know,
you
you guys can't believe it, right? Yep,
And
yep,
this kind of maybe blends into another question I have about for folks looking at the virtual setting too is
yeah,
how do you manage the medical fragility or the medical care piece? And then, of
yeah,
course, for people who aren't getting nutrition and aren't eating, how do you do
yeah,
that?
for sure, yeah, that was a big, big thing for us. How are we gonna manage this? Like, well, first and foremost, we do a very deep medical clearance, so we
You
know
do.
when somebody's coming in. We
Hmm.
have incredibly skilled, clinicians that do the medical clearance, review the medical clearances, so we really know what's happening. We do take patients out within that many patients who might otherwise go to residential. Now, that does not mean just to be clear, I would never come out and say that we're a substitute for any level of care. And I know some places have come out, I would never say that all these kinds of programs are needed for different scenarios that patients are in. I will say, though, however, that we have successfully treated many a patient who might otherwise be in a residential. So we can go down to, depending on the circumstances, go down to 70% or so ish of ideal body weight, and we always really know what we're admitting before we admit. Make sure, that we know their vital signs, our heart rate, electrolytes, orthostatic signs, other medical symptoms, other psychiatric symptoms, suicidality. Super excited. I've had the same psychiatrist, Dr. Sam Moss, since inception, and he's just a really humane, wonderful psychiatrist that's involved in the medical clearances, and Karen Gutierrez, who's a nurse practitioner that's worked with me since 2008. And then more recently, I have Dr. Dennis Gibson, who is a lovely physician that previously worked at Acute in Denver, and
Mm,
he oversees the complicated medical clearances and
good.
anything medically that comes up at within. So we have an incredible medical team and then really talented nursing pool that is very well trained, led by Chrissy Stalker, who has worked in the field with me since 2008. I believe that nurses are really important for eating disorder treatment. They're
Mm,
trained using a biopsychosocial approach, kind of like psychiatry, so they can
yep.
cover a lot of bases. A lot of times they're doing the education I was mentioning. They can talk about so many facets of the illness and recovery. So, and then we do remote patient monitoring. So we can really closely monitor weight restoration and vital signs. Everybody gets devices sent into their home so that we can do real time remote patient monitoring, vital signs, temperature, blood pressure, all that. So we really know what's going on with the patients on as frequent a basis as we need to. And then on the nutritional piece, we really believe that this is incredibly important. If somebody is sick enough to need like a PHP level of care, then we have to make sure we're doing exposure therapy. So we do send meals into the home. We've delivered, this was last year, we surpassed the 50,000 mark as far as the meals that we've sent into the home.
Wow.
So because we want them to do exposure therapy. We'll not cut the corner
Mm,
on that. So they do get meals sent in, and we have a meal support. And we have also a secondary approach for people who are really struggling, that they might even just have one-to-one meals or very
okay.
small groups. Then they can sort of, if they're struggling, they can sort of, if you will, graduate to the milieu with, like, where there's a few more patients, and it's sort of just very structural and very clinical and very like, let's get this food in the mouth, to a
Right.
more social and positive reinforcement. We've just had to go very far. We call it an enhanced model. It's really like, almost in some cases, it's almost a substitute for some people for residential. Again,
Okay.
not to say many people actually have to go to a brick and mortar residential,
Right.
period. Or we bring them in and they don't do well, and then, like, we have to get them to a, that happens.
Absolutely.
Sometimes we get people in that refuse to go to residential, and we're like, our job's going to be to help them go to a residential, probably. And that's okay too. We're just helping people get
Yeah.
well. But thing that we've had to do, and when this has been very organic, is just create a lot of other support. So at within,
Okay.
the care is really individualized to their schedule. So
Yeah.
you could be like, yeah, I have to do this at 10 o'clock on Tuesdays and Thursdays. So, okay, you're going to do, if you're like in PHP, or maybe you'll do a meal together, an individual session in the morning, go do your thing from 10 to 1, maybe you'll do your meal on your own for lunch, and then you'll come back for a group and another meal at dinner. We also
Perfect.
have things called the living room. So if people need that extra meal support, they can do that. Or if they're just having a tough day, or we've, got triggered, there's this living room concept that was taken from, when you have a treatment center, people get well sometimes hanging out in the living room together, talking with each other.
That's
So we
it.
have a living room
Yes.
available all day up until 10
Love
p.m.
that.
everyone's time. So you could just pop in, and
Oh, I love that.
we have an app that people can communicate with the whole multidisciplinary team. So there's just way more treatment than a traditional PHP at Within, because that's what people need. Everything we've been creating at Within is a derivative, like, of what we've seen that the patients need to heal.
I do feel it evolving because I remember when you guys were first out and we'd be referring and I've just watched as more,
Yes.
like you mentioned, the enhanced care. And I mean,
Yeah.
I'm asking you some rhetorical questions because I
Oh,
do know how rigorous your medical
oh, thank
approval
you.
is. I
Well,
want them in the right place.
yeah, we're trying to
Yeah.
speed it up. Now that we have Dr. Gibson, that has helped a lot, because when there's a complicated case, we used to, like, have certain number of meetings per week where a few of us would eyeball the case together. Because we'd want to have the clinical and the medical and the dietitian. We'd want
Mhm.
to, like, because we want to make sure people are not getting admitted that need, that aren't going to, obviously, make sure that they can be safe. But now we
Yeah.
can really, just strike up a quick conversation between Karen and Dr. Gibson, or Sam and Dr. Sam Moss and Dr. Dennis Gibson. So we could just
Talk
do
about it.
things more, more. We've just created more efficiencies. And
Good.
having Dr. Gibson's been such a blessing, because with Dr. Moss and Dr. Gibson, just such strong psychiatric and medical care. And then Chrissy as a nurse, and Karen Gutierrez as a nurse practitioner. We just got such strong clinicians that we can really look at a case and go, can we bring this on, or do we really need to not bring it on?
And other than medical fragility, are there other things that a person thinking about, hey, is a remote setting like within for me? Are there other questions they should ask themselves to know whether or not you're
Yeah.
the right setting or if they need to be, like you said, in a brick and mortar?
Yeah, that's such a good question. I should say from the outset, it's in a general way, there's some specific rule outs for sure, but in a general way, it's really hard to predict who's gonna really respond to the environment. I think
Yeah.
some people who have really got a track record of having a very tough time, they they really respond well. I think not having to give up so much autonomy and feeling, like, more grounded. A lot of times the battle in your brick and mortar is the battle about keeping them in treatment. Well, they're already home, so it's like, we're not having to fight. You're with your dog, like, you with your it's like we don't
Right,
have to
right.
battle that out. And I think the respect that people feel when they're able to work in their environment, sometimes that invites, like, the healthier self, to the party. So we can't really say, oh, this one's been so compromised, so therefore she or he is not going to do well. I don't think that's the ticket. I think that even just the smallest amount of willingness to try is a very good start. The smallest amount
Yeah.
of willingness to try is enough. However, I will say, if the person's actively psychotic or actively manic or really cannot stay safe from a suicidal point of view, which we have to assess very seriously in this population, from extreme self-injurious behavior, substance abuse. I always say with the substance abuse, if they're kind of at a level where they would be IOP level or lower level of care with co-occurring, if there's a level of motivation there and if there's a level of accountability and support there, we really can do a very nice job with substance comorbidity. There has to be some things. We do look for some things to be in place. We tend to not admit opiate dependency because of the lethality there. We don't take patients generally below 70% of ideal body weight. Those patients generally belong in a hospital anyway.
That's fair. Yeah,
Yeah.
then they need to be in more medical setting.
Yeah.
Something I hear that is perhaps a complaint, clients will say, well, we didn't talk about that in treatment. That's supposed to be for when we're discharged and we're out of treatment. And things like you mentioned, the pursuit of thinness, body experience. Do you address that in your programming, or is that something that is not set for these
Oh,
places?
no, we address it. Yeah. I think,
Yay. I
yeah, I
figured
think,
you did, but I had to ask.
yeah. Oh, thank you. I mean, I think again, biopsychosocial. I mean, the
Yeah,
psychosocial
big deal.
variables, like the impact of diet culture and weight stigma on our patients is like profound. And, every person with an eating disorder, minus maybe ARFID, is profoundly affected by weight stigma. And so as I've evolved, I've really come to believe that like fighting weight stigma, addressing weight stigma, that should be on your treatment plan. Like, how are we going to help this
Right.
person combat diet culture? Even at within, like, even though they're out in the world, like they have this bubble of connectivity of the team and the philosophy and that safety. How are we going to help them like hold on to those
There.
pillars after they leave? So I really think addressing that in a very committed way and with enthusiasm and excitement. I have a slide that I love where it's a lion, and I always picture this lion. I was like, I tell people, especially those in larger bodies that get especially hammered by weight stigma and the poison of weight stigma, try to have them visualizing a lion. I'm like, anybody gets in your relationship with food or your body, like you let out a roar, like, not allowed, dude, get out of my, it could be the doctor, it could be the family
Anyone.
member, the number 1 and 2 perpetrators of weight stigma. You got to help your patients be ready for that.
Oh, yeah, we can't keep that insular world that we all try to create and expect them not to be shocked when they walk out the door.
Exactly.
It is a
Exactly.
tough world to do this in, isn't it? Oh
It
my
really
gosh.
is. It really is. That's why we have the alumni program too at within the free alumni program. We're setting up some other programming for people post discharge too, because I think that's one of the hardest things. Like that's why it is so cool. I love addressing, the acute phase of the illness, but then like the reintegration piece,
Yeah.
which is also a part of what we do at Galen Hope, the really strong attention to community integration because man, they're going to come out of our care where we've really, really fostered this diet, anti-diet culture mindset and just be bombarded with diet culture, So how do we get them to generalize that? Well, you got to talk about it and make it a part of your treatment plan, I think.
Yeah, and hear from others that are like-minded on a regular basis, like your alumni groups, that this isn't my
Yeah.
language. I don't have to adopt it.
Yeah, it's so
I get
hard for the therapist to just carry that in, like, the therapist, they may see them once or twice a week, but they're
right?
out there, like, bombarded
Gosh,
24/7, so
everywhere.
yeah.
Even dog food now, like I have a puppy and I was getting him dog, and all the dog food has like calories on it, and the ones like lower calorie dog food, I'm like, I'm really confused by it.
I I'm so glad you brought that up. When I saw that, I was like, "Okay."
Right.
Somebody said that about a cat, an O cat, and I'm like, "Can't we just have, like, big cats? Can't we have big people, big cats,
Right.
big dogs?" Like,
Right.
size
Right.
diversity is normal, like,
We
let's
have to have it. It's a part
yeah.
of our evolution
It's our
anthropologically.
survival, yes, so,
Yeah. But the cat
yeah,
cracked me up. I'm like,
that's
my dog doesn't care. He has no body image
your dog
concerns.
is good, yeah, your dog is, like, happy, just your dog was like, "Can I have lunch? I want it to taste good." I
And I
want
want Within to send it to me. I love that you send meals. Hello, that's great.
oh,
Takes
I
the
love
decision out of it.
yeah, it was really interesting to figure out which meal company to use. We tried so many different things, but yeah, it's
Yeah.
been quite the journey. I was blown away when I was like, "Wow, we've served more than 50,000 meals." I don't know where we're up to now. We were at 50,000 last year. That just blew
Wow.
my mind. I was like, "Wow."
That's a
It's a lot of
lot.
meals.
And that's another concern for folks in virtual is they're like, "Well, if I'm given too many decisions about food, I'm gonna make the wrong decision, or I won't make a choice," and you're making that easier.
Yeah, that's a part of
Yeah,
exposure therapy. It's like if
yeah,
you're ill enough that you need that level of care, like, I can't imagine that you're at the place to, like, bring, exposure-oriented, recovery-oriented food. Like, if you could do that, you probably wouldn't need this level of care. So it's just
great
I
point.
think it's a part of being responsible to the patient's recovery by making that investment.
Yeah, I agree. Do we have metrics on virtual care? Or I keep calling it virtual, you're gonna help
Yeah,
me say
that's
remote
okay, that's okay.
because I
Yeah.
love remote. We'll get
We
there.
are very committed to measurement-based care. Dr. Caitlin Shepherd is our leader with that, and since day one, we've done measurement-based care in a
Yeah,
very serious way, meaning that it's not just doing before and after and beginning and end of treatment. We do
right.
ongoing measures, and, Dr. Caitlin Shepherd really taught us really how to do that well, and we bring the measures into treatment with the patient. So the patients examine their outcomes on a
Beautiful.
as these measures are done generally on a monthly basis. And the patients and the therapist and clinical team explores the measures together and thinks about it together. So it really becomes it's not just measurement for our purposes, it's really a therapeutic process. And then, beyond that, of course, holding ourselves accountable to our own outcomes, and the
Yeah,
outcomes that we have seen are on par with brick and mortar programs, and depending on the report,
good.
in some cases even improved upon. And we've
I've
also
seen
been
that.
very committed to doing post-discharge measurement-based care, and we've gotten, relatively speaking, very high response rates for post-discharge treatment, which is very hard to get, and we've seen that patients go on to continue to improve post-discharge. So I remember when I first heard the statistic. It's changed a little bit, but I think the first round I got back from Dr. Caitlin Shepherd, and she said, yeah, like 70% of our patients are out of the clinical range on the EDEQ and the PHQ-9 at the time they discharge. It's a little different than that now, but it's like roughly a 70%.
Good.
I was really blown away by that. I think I was really blown away by we've done, where we separate out the patients that have higher symptoms, like higher EDEQ scores, higher PHQ-9 scores, and really seeing how those patients have done really well. Another outcome that I'm really excited about is the measures around quality of life for some of our really, really more sick, complex patients, like really improve quality of life. So sometimes we haven't seen necessarily the outcomes that we wanna see on the EDQ, but we see these quality of life indices improve, like, that just makes me feel good, like, we're helping people
Yeah.
feel better in their life. So we're very strict about measurement-based care. We have very high expectations that there isn't a patient that comes. I mean, if you're at within your or Galen Hope, like, it's not like we have 70% of our patients are doing it, like, it's like 100% of our patients are doing it. We have to see how we're doing, we have to see how they're doing objective.
Yes. And you need it for to show your own efficacy and to show that this does work and to keep building these type of programs. We need these everywhere.
I
I mean, you are everywhere, but
Yeah, I was so lucky, honestly. I have to shout out Dr. Jessica Janae. She's a clinical psychologist that worked for me at OPC, and she helped us start within from ground zero. And she didn't really want to have to handle research, but she had handled it from before. And like, Jessica, we have to do
need
it
it.
because we don't
Have
know
to
if
do
we
it.
can do it. So we have to do this. And so she set it up
Yeah.
for us. And then Hannah Wolf is also works with Caitlin Shepherd. They've just taken it from there and just done a great job with that
Yeah.
process. And yeah, and Galen Hope also as well. We actually won an award at Galen Hope from Green Space for highest symptom improvement about it was like 500 programs. So we've seen some really great outcomes there. We've seen
Good.
some really interesting and outcomes that I think surprise the field that have to do with engagement. People think, oh, how are people going to engage in like remote care? Well, we have very, very high engagement at within in remote care. So that's also been really interesting.
We mentioned earlier that COVID allowed, at least for people in my practice, to do virtual, and it's amazing how effective it can be. I would not have guessed it.
I know. So do you do a lot of remote care or do a little bit
I
of
do
everything?
half and half, but
Nice.
my colleagues and our practice here, I would probably say it's more like 60/40, maybe 70/30. I
Mhm.
prefer when I can do in person, but there's
Yeah,
clients who have recovered. I'm on their team and I've never
yeah.
met them. in person.
That's really
Yeah,
interesting.
it works.
It is lovely to see people in person, I have to say. We always enjoy that, but man, the patients have some really strong connections. We've had some, little reunions of people at like, we've had some patients get together in different places, like alumni after they left treatment, and get
Yeah,
together and meet in person. So that's really exciting when you see the relationships building post-treatment, so
I love
kinda
it.
yummy.
And our younger populations are so good at this setting. They're just like, I
I
see you. We're buddies. We can be remote. Speaking of which, what are the ages that are served and any demographic or ages for both facilities we're talking about?
Sure, yeah, so within can go down to age 13, and we've had
Okay.
patients at, over the age of 70, at within, and then at Galen Hope, at our PHP and IOP level of care, we've gone down to 9 or 10. There's not a rigid cutoff there, kinda has to do with we do have an adolescent and adult program. Within has an
Okay, okay.
adolescent, adult, and mature adult. And then Galen Hope has an adolescent and adult program. And then our residential at Galen Hope, the lowest we can take, unfortunately, is age 13 to
That's
8.
still pretty young.
Yeah, yeah. To have this need for residential for the youngsters and we try to just involve the family as much as we can because it's
Yeah.
so sad when that need comes into play.
Yeah, it's a very unique setting for them.
Yeah.
ARFID, do either I know within manages ARFID. Can you just talk
Oh,
just
yeah.
real briefly on how ARFID is also addressed in these?
Oh, yes. Oh my gosh. ARFID. I mean, I think addressing it, not necessarily, of course, it's an eating disorder, but thinking of it as sort of depending on the presentation, either a phobia or thinking along the lines of a trauma and all the different, reasons that the main reasons why people can develop ORFID, and then approaching it as a very collaborative, exposure based
Mhm.
hierarchical, like collaborative decision. Like, what food, if you were able to eat it, would really be meaningful to you? Like, what would help you improve your quality of life? And really having conversations collaboratively with patients. We have our own ARFID group and table at within and at Galen Hope. And many of our patients at Galen Hope, because we have primary mental health, many of our patients with ARFID, they actually eat with our primary mental health patients. Can do exposure therapy and just a different approach because there's different things going on for people. And then we have a very large cohort of ARFID patients. We have a lovely ARFID process group at within. I think it might be one of the larger process groups of any treatment program and separate ARFID meal support as well. But I would say overall, it's very collaborative, humanistic, and exposure therapy based with a strong buy-in from the patient of like what really matters to you. How can we improve
Yeah.
your quality of life?
Yeah. Because you're maybe aren't gonna get all of it, but you're gonna get just what you said, what's gonna make you live a better life. Don't have to eat everything for that.
Yeah, yeah.
Oh, I love that. Now, I
Yeah.
will put in show notes and everything information on how to contact, but is the best thing for folks to start with their outpatient team and then work on the referral, or can they just go directly to these sites and
I mean, we love when we have the outpatient people involved. We think of it,
yeah.
as cliche as it sounds, it really is. It really does take a village. And I always tell our outreach team, like, when we're building these relationships, it's like it really is a community that surrounds a patient with what I call love and boundaries. And so when we have that connection with the outpatient team, it really helps reinforce what we're doing. And the patients, when their outpatient person's like understands the program and as everybody's sort of bought into it, it makes treatment completion happen better. It makes getting into treatment easier. So we love it if the person can, have the outpatient person or persons in their life be a part of that. I think it really helps people make the decision to step in and when if and when, more like when there's something that comes up in treatment, the person is upset or wants to leave early or doesn't agree with something we're doing or whatever,
Yeah.
that connection with the outpatient provider is very important. So we send like a data and updates. Some people say ridiculous. I don't think so,
No,
but
not
we
at all.
send a lot of data well, you've had patients maybe at within, like we
I
always
have.
send updates. So we want to make sure the last thing I want is, and I've heard this story of like somebody not even knowing what was going on with their patient treatment, then all of a sudden they're on the schedule and they haven't been informed of what's going on, or they didn't
It's
even
the
know they were about to
worst.
discharge. All of a sudden they're on their
Right.
schedule. So we're kind of the opposite of that. We're kind of annoying, I think, and a little bit intrusive, maybe. I'd lean that way more than having, because the outpatient person's carrying the person along. We get them for like maybe 90 days. The
Right.
outpatient team's like with them for years. So
I
if we know
agree.
more what's going on before the person comes in, we're just way ahead from ground zero. So
Exactly how it should be. And then I know how to prepare for when my clients are discharging and coming
yeah,
back, and I can
yeah.
talk to your people and find out what we need, and
It's more fun and
yeah,
collaborative and like it's better for the
right
patient, better for everybody. So
back.
yeah.
I know we're getting close on time, but you've done so much in this community, more than I could even gather in time with you. But do you have a aspiration, a hope? What's a future thing that you would love to see in the eating disorder world? Let's think big for a minute, I guess. Not that
Um,
you already haven't.
oh, you're so kind. I mean, I'm very excited about co-founding with my partner, the Eating Disorder Education Institute, because, if you look at some of the research says the number one and two things that impact whether or not somebody has prolonged duration of untreated illness is, for example, a lack of a PCP that knows about eating disorders in their life or lack of exposure to recovery stories. Those are some. So I think that there's too much of a limited world of trained folks that actually really know about eating disorders. So with the Eating Disorder Education Institute, I'm excited to like really try to expand the world of folks that really do have very good understanding of eating disorders. So that's something really exciting. And I'll end with this, little story. When I did my residency at NYU, there was no training on eating disorders. And that was a very long time ago. And guess what? There still is no training on eating disorders this many years later. So I said, you know what? Screw it. Like I kept waiting for somebody to do it. And I'm like, you know what? I'm doing it. I'm just going to do it. So we've created the Institute, and it's for multidisciplinary training. We have some of the best, I think, most amazing clinical folks doing the trainings and the certification and the credentialing. So that'll be starting in September. And one of my hopes and dreams is that within the field will expand, but I really want to see specifically, I want to see doctors and psychiatrists have mandatory eating disorder training because I think that's where a lot gets missed. I'd like to
Please.
see when by the time I'm done in the field, I want it to be that, psychiatry residency programs require eating disorder treatment. I mean, 30 million people have the condition. It's the second highest
Mm.
morbidity and mortality. Like, how the hell do they not have mandatory eating disorder education for psychiatrists? So I guess that's one of the things I'm thinking about right now.
I love it. We have this mini school education program we're working on here, and I know ANAD does this too, where we're
Yeah.
trying to train teachers and coaches and
Oh,
health
that's
teachers.
amazing. Yeah.
But it's so hard, right? And so you're creating this coalition that it's almost like creating a rubric up above that we all
Yes.
need to learn more. That's going to help what I'm doing too.
Well, that's
I
really
want to
cool.
sign up. How do I sign up?
Oh, please do. We would love to have you be in our first cohort. We would absolutely love that. So I'll send
September,
you.
right?
Yes, we're very excited. We have our constellation of about 12 different courses, everything from the medical complications, Jen Gayani's.
She was on here, and I just sat there and listened to her the whole time. I was
I
like,
know she's fun to listen to.
she's so great.
But that whole composite of courses, and then we're doing a practicum. We're really excited. It's going to be really done at a high level, and we have a Harvard educated educator that is helping us design all of our courses. So there's a lot of thought that's going into it. I'm very excited about
I
introducing
love
that
it.
to our field and beyond our field, so more people can have education.
Anyone, right?
Yeah, there's going to be a certification for people who aren't necessarily wanting to be, primary eating disorders, but just want a basic. So, I envision patients that go to like a substance abuse program and the clinicians don't know anything about eating disorders. So just expanding the world of individuals, multidisciplinary that have that fund of knowledge, that's for the certification. And then the credential will go beyond that and have the practicum as a part of it.
I think it sounds fabulous. I love it. We'll spread the word here. And our practice owner often has fellows here
Oh,
and
cool.
pediatricians, and we train them on eating disorders
Oh,
because they
that's
don't get any.
they
So
don't, right? That's great. I
no.
didn't know you guys had felt. That's really cool. That's really
She
lovely.
does whatever we can do in our little stamp, but your stamp is bigger, so I'm gonna connect her stamp to your stamp.
I
I
appreciate
love
it.
it.
I really do. I appreciate everything that you guys do. Thank you for allowing me to be a part of your wonderful podcast. I really, really appreciate it.
I'm trying to do what you are, get more awareness and visibility to eating disorder
Okay,
care and mental
good.
health focus. So
That's
that's what we're doing.
amazing. That's great. I mean, these conversations are really powerful for folks to just understand that it's, it's as you were saying, it's not something to be ashamed of if you're struggling and there's like a way through it. And there's humane care and humane people giving that light. You're shedding that light on the community at large. My hat is off to you.
Thank you. I'll take it.
One
I'll take a
soul
little
at a
bit of all of
time,
it.
right?
Now, I do have one more question. It's my favorite.
Okay.
Do you have a word to describe this incredible journey you've been on since you were at NYU all the way to now?
I think that I've used the word hope in a lot of the things that I've done. I like the word hope, and this is more than a word though, but hope would be a word that I would say. And I combine the combination of like, this takes work. So the definition of work is dictionary definition is something like mental or physical energy directed toward a goal, right? So that's work.
Yeah.
And I think of hope is like the fuel to help you do the work, right? If you don't have the hope, then you don't have where are you gonna, you have to do this work. Patients that are doing treatment are working. They're doing hard stuff. They have tears coming out of their eyes when they're eating, the hamburger. So that hope is something that we have to hold sometimes for our patients and continue to have the hope. So I think hope is really important. I have a thing about untapped potential. When I see somebody or I meet somebody, whether personal life or professional life, I get really excited about like what I feel like is possible for them. So that's something that I think having that hope, even if the person's not feeling much of it, like if you're holding that hope or you're seeing that vision and then you're in the relationship with the person, they feel that. And it's so healing. It's such a profound experience to help be a healer in somebody's life. I just couldn't trade it for anything. Well, it's
Beautiful.
so special the work we do. So, and I
I
think
bet.
all the providers that we get to meet, we're a special bunch, we're good. We're good people.
What we do, what we get paid, we're pretty awesome.
I know.
We're
The
awesome
battles we
people.
fight.
But I appreciate not only you coming in and talking about this with me, but my intention, I always set an intention, was to listen deeply, and I learned much from you today, and I
Oh,
so
that's so
appreciate your
kind of
time.
you. So generous of you to listen to me ramble on and on. Thank you so
Oh,
much.
I've been enlightened and ignited. I'm gonna go change the world when I get off this call. I mean, after I'm done at work, that is.
Oh, well, I hope to meet you in person sometime, speaking of in
Yes.
person. And I know you guys just did an
Yes.
event, so hopefully I can get up there sometime. Really,
We would love to
really
have you.
mean it. Thank you for having me. I appreciate it. It's been a
Absolutely.
joy. Thank you.
Thank you, Wendy. Thanks for listening to the Mental Health Spotlight podcast, helping you hold hope on your recovery path.